Today's topic is tumors of stomach. First classification. Tumors of stomach are divided into primary and secondary. Secondary tumors do occur in stomach, though they are unusual. The malignancies which are known to metastasize to stomach are carcinoma of breast and melanoma. And of course, extension from surrounding malignant processes like gallbladder, hepatomas, pancreas, but they're very unusual. Most of the tumors of the stomach are primary. They are subclassified into benign and malignant. Benign tumors are polyps. There are two types of polyps. One is non-tumorous polyps. They are hematomatous polyps and hypertrophic polyps, which never undergo malignant change. True benign tumors are called as adenomatous polyps. They are single, they are multiple. Sometimes the whole stomach is full of them, and it's called as polyposis, adenomatous polyposis of the stomach. They can become malignant. The incidence of malignancy solitary adenomatous polyp is less as compared to multiple polyps. Malignant tumors are adenocarcinomas, GIST, gastrointestinal stromal tumor, and lymphoma. These three malignant tumors constitute almost 99% of malignancies of stomach, out of which 95% are adenocarcinomas. Other histological subtypes which I have described with stomach are endocrine tumors, carcinosarcomas, angiosarcomas, and squamous cell carcinomas, especially for upper part of stomach, esophagus. Most of the tumors are adenocarcinomas arising from the mucus secreting cells of the stomach. Etiology. Etiology of carcinoma of stomach is not known, and as and when we don't know the etiology, we speculate or we try to find out factors which predispose to malignancy and if there are any pre-malignant conditions or not. Factors which predispose for malignancy are: number one, age, so disease of an elderly, usually beyond 60. Sex, there is a distinct male preponderance, 2 to 3 males to 1 female. Geographical distribution, true, absolutely true, there is a geographical distribution. The Eastern European countries and some Asian countries have a very high incidence of carcinoma of stomach. Japan tops the list. As far as the incidence of adenocarcinoma is concerned, the Western world quotes this is the 4th or 5th leading cause of death in men. Most of them come in with late presentation. Other predisposing factors are diet. Diet rich in fat, diet rich in nitrates, diet rich in salt, tinned food, salted food, smoked food give a higher incidence of malignancy. It is seen that people who stay in a high incidence area, geographical area, carcinoma of stomach, if they shift to low area, after a few years, the incidence drop. Whether it is related to geography or diet is not clear, but this is a fact. Japanese who have shifted to America, the incidence of malignancy of stomach in Japanese and America is lesser as compared to in Japan. There is a familial incidence also, about 10% of the patients give family history. Related to smoking, alcohol, these factors are very vague. There are few pre-malignant conditions also. Number one, I said, was polyp. The multiple polyposis is more prone. Number two is residual stomach residual stomach after gastrectomy has a 4 times higher incidence of malignancy because of anastomosis with jejunum and intestinal metaplasia. Number 4 is ulcer, gastric ulcer. This is the old concept. Gastric ulcer becoming malignant is no more holds true. Malignant ulcers malignancies in the benign looking ulcers detected on gastroscopy in stomach are always malignant. Benign ulcers do not undergo a malignant change. Then comes H. pylori infection. Regions where H. pylori infections are more, the incidence of malignancy is also more. H. pylori infection first produces atrophic gastritis, after the dysplasia, and then malignancy. There are some areas where H. pylori infections are common, but incidence of cancer is low. This is not clear. If you detect H. pylori infection, should the infection be eradicated to reduce the incidence of malignancy? Is not clear, because there are areas where H. pylori infections are common, but malignancies are not that common. This is a debatable point. Sites of malignancy. The most preferred site is lower stomach. Lesser curvature, lower part of body, antrum and pylorus represents almost 70% of malignancies of stomach. Upper part of body, cardia and fundus account for about 30% malignancies. There are some countries in Europe, the incidence of upper gastric cancer is increasing for reasons unknown. Then comes pathology. Pathology we could discuss under the heading of macroscopic, microscopic, spread, staging. The macroscopic type, there is a Lawrence classification saying that there are 2 basic types of malignancy. One is infiltrating and second is intestinal metaplasia. But it takes 4 types of macroscopic appearances. Number 1 is ulcerative, classical malignant ulcer with everted edges, size large. Second is polypoidal. The third is fungating, and the next intestinal metaplasia type, the diffuse or infiltrating type. The ulcerative type presents the classical malignant ulcer. Polypoidal type is an exophytic which grows into the stomach. Fungating is combination of ulcerative and polypoidal type where the mucosa breaks. Infiltrating type, these exophytic type of malignancy has a less potential to infiltrate in the stomach, therefore they have a slightly better prognosis, and they are the ones which present with palpable masses also. The infiltrating variety is divided into 2 types, the localized type and diffuse type. These are more malignant, more dedifferentiated. They tend to infiltrate the wall of stomach, lead to thickening of wall, flattening of the mucosal folds. It narrows the stomach, and when it starts in the pyloric region, presents with pyloric obstruction, and it gradually proceeds to involve the entire stomach, leading to small contracted thickened stomach, classically known as T-back stomach or Lenitus plastica. Converting stomach into a thick bag, narrowed bag, called as Lenitus plastica. The importance of these appearances was very important when barium studies was the diagnostic investigation used, because they would produce various other kinds of defects different from each other. A polypoid would present with a feeling defect, ulcerative would present with the classical mental ulcer features, the fungating would present in different manner with barium going inside the malignant tumor. The infiltrated type will present with contracted stomach, flattened mucosa. At that time, the appearances were very important. But even today, when the diagnosis is done by gastroduodenoscopy, a person who does a scopy must know how a malignant tumor appears. Then alone he can say this is malignant or not malignant. As far as ulcers are concerned, the biopsy is absolutely essential. Sometimes malignant ulcer acted upon by peptic digestion mimics a benign gastric ulcer, and therefore diagnosis by histology is absolutely important. The description of these types is not merely of topographically important, it is important from the point of view of diagnosis also. Spread. You name method of spread, and carcinoma stomach is known to do that. It spreads by local invasion. Local invasion, it deepens, penetrates the wall of stomach. It is capable of penetrating serosa. It is capable of involving the surrounding structures. It not only spreads in the depth, but it spreads sideways, upwards and downwards also. Second important spread is lymphatic. There are two methods by which lymphatic spread. One is embolization, the second is permeation. Carcinoma stomach spreads by both the methods. It permeates as well as embolizes. Permeation is responsible for submucosal intermuscular involvement of stomach much beyond the visible sites of malignancy. Therefore, we say when you talk of a radical surgery in carcinoma stomach, you at least have a safe margin of minimum 5 centimeters on either side of palpable or visible malignancy. The importance of embolic spread is, this explains why sometimes a lymph node much away from a site of malignancy is involved. The embolization, because of rich arborization, can produce metastasis in lymph nodes in farther areas than regional lymph nodes. The lymphatic spread is known to take place along the ligamentum teres ligament, and from there it not only goes into liver, but its cells drop in the peritoneal cavity, producing peritoneal metastasis, and classically is Crooked-Buck's tumor. The cells falling on ovary trapping them, and it producing a malignant tumor of the ovary. The third method is hematogenous. Hematogenous is the most common organ involved is stomach, but bones and lungs comes through, come the third. But there is no place in the body where stomach carcinoma, stomach advanced, is not known to metastasize. The fourth spread is peritoneal spread, where the malignant cells shed into peritoneal cavity and involve gastrocolic omentum, greater omentum, and you had multiple nodules of malignancy spread in the peritoneal cavity. The dropping or peritoneal spread by sprinkling is also very well known in carcinoma stomach. Next is staging. The classification is American Neural Society, which has introduced this classification. They divide into 3, N, T and M. T stands for tumor, N stands for node, M stands for metastasis. T1 is where the tumor is restricted to mucosa and submucosa. Japan is the only country which divides this further into 3 types, A, B, C, or type 1, 2, 3. No other country indulges in dividing T1 into any other factor. Since we are not in Japan, there is no need to discuss about it and complicate the matter. T2 is when it goes in the muscular area. It involves the muscularis, that's T2. T3 is when it goes to serosa. It involves the subserosal loose areolar tissue, but serosa is intact. T4 is divided into 2, A and B. T4A is when the malignancy invades the serosa but has not involved the surrounding organ. T4B is when it perforates the stomach and involves the surrounding organ. N0 is no metastasis in lymph node. N1 is lymph node metastasis close to the malignancy, not more than 2 lymph nodes. N2 is when 3 to 6 lymph nodes are involved, again in the region where the malignancy is situated. N3 is when 7 to 15 lymph nodes are involved, but they are again close to the malignancy, close to the stomach. N4 is more than 15 lymph nodes are involved. Here you have spread anywhere in the drainage area of the stomach. Then comes M. M is metastasis. Wherever there is a metastasis, it changes stage straight into 4 irrespective of T and M state, irrespective of T and M state, T and N status. If you try to classify this into stage 1, stage 2, stage 3, stage 4, stage 1 is T1, T2, N0. Stage 2 is T1, T2, N1, N2. Stage 3 is T3, N3, T4A and N3 is stage 3. Stage 4 is, stage 3 is excluding N4, excluding T4, which T4B is stage 3. What comes in stage 4 is metastasis. Some people include T4B, N4 and metastasis in stage 4. Some people put N4 and N3, N4 and T4 in stage 3, especially Japanese, who are known to do extensive surgeries for carcinoma. The rest of the world, N4 and T4B is put in stage 4. Then comes clinical presentation. Clinical presentation is unremarkable. It is surprising that stomach which weeps for pregnancy, which weeps for head injury, does not weep when the malignancy inhabits it. It is a very well-known malignancy to present very, very late. Most of the Western world, Japan quotes that malignancy because they have endoscopic surveillance of their population every 6 months. Therefore, they catch malignancies young. The incidence of stage 1 presentation in Japan is as high as 70%. But nowhere in the world this percentage has touched. Most of the malignancy in Western world, where there is no surveillance, less than 25% present in stage 1 and stage 2. 75% present in stage 3 and stage 4. You can imagine the status with us, more than 80%, more than 90% present in stage 3 and stage 4. If you look at the symptoms, therefore, in early malignancy or operable malignancy, the symptoms are minimal, except that you have an elderly patient, might have a dyspepsia for a few days, a few weeks, with tremendous loss of weight, tremendous loss of appetite, emaciation. Once in a while, mild epigastric pain, once in a while, vomiting, melena, once in a while. Hematomasis is very unusual, less than 5% bleed. Clinical examination, apart from these general features, does not show anything in early malignancy. In late malignancy, therefore, in a patient, a man who is elderly, who loses weight, who has loss of appetite, who has tremendous anemia, and has an upper abdominal symptom, any upper abdominal symptom, is essential to exclude carcinoma stomach by gastroscopy. It is one of many diseases where this combination exists. One of them is carcinoma stomach, which you need to exclude. Advanced malignancy, there are several signs. Number one is a palpable mass. A palpable mass which is mobile, 95% are inoperable. Palpable mass which is fixed in relation to stomach, 100% are inoperable. Other areas which you look for in the abdomen is palpable liver, hard nodular liver, ascites. Carcinoma tumors are usually not palpable. Left supraclavicular gland, Trouche's sign, axillary glands, pleural fusions, anemia, edema feet, PR examination showing Blummer shelf, malignancy which cells which drop in the pouch of Douglas, thrives there, and PR examination you see extrarectal mass, hard mass on the antiwall of rectum. Here the diagnosis becomes very easy. Diagnosis becomes very easy, but your burden of making treatment or planning treatment also becomes less. When you come to diagnosis investigations, there are three purposes for which you investigate a patient. Number one is establish a diagnosis. Number two is find out preoperative stage. And number three is general assessment of patient. By and large, patient is elderly, has comorbidity, has effect of carcinoma stomach. Therefore, general investigation becomes very important. Maybe one of the reasons why a massive surgery, extensive surgery cannot be done in such a group of patients. This forms a very important group, though we don't discuss it. Diagnostic investigation is gastroduodenoscopy. Most of the malignancies are clear. Since I said most of them present in stage 3 and stage 4, the malignancy, whatever form, whether polypoidal or ulcerative or fungating or infiltrative, the appearances are clear. All of them need biopsy. Wherever you are in doubt, where ulcer is seen, which does not look malignant, it's more important to take many biopsies. An ulcer is seen which looks malignant, here also histopathological diagnosis established is the first step before you start your management. Therefore, I have no words to emphasize the importance of gastroduodenoscopy and biopsy of a lesion which you see in the stomach. Number two is CT scan. CT scan is meant for not only local invasion, but gives you information about rest of the abdomen, liver, pancreas, fluid in the abdomen, Carcinoma tumors. Most of the investigation for us stops here. But for people who go ahead, they have other investigations. Next one is PET scan. PET scan is meant to demonstrate metastasis. It's usually done for stage 3 and 4. As a matter of people do it for even stage 1, stage 2. This is to demonstrate the metastasis in the body. The fourth is PET and spiral CT scan together. This is not only assesses the general metastasis, but also assesses the loco-regional spread of a disease and feasibility of an operation. This is more important in stage 3 and 4, where extensive surgeries are planned, whether the malignancy is removable or not. I forgot to mention one thing. Extension of a carcinoma stomach into an organ which can be removed is not taken as inoperable. The signs which I mentioned, advanced malignancy, they are all signs of inoperability. I said left supraclavicular lymph node, axillary lymph node, malignant ascites, hard nodal liver, Blummer shelf, pleural fusion. They are all signs of clear-cut signs of inoperability. One which I did not mention was if the surrounding organ is involved, except an organ which can't be removed, like aorta, posterior abdominal wall, involvement of surrounding organ which can be easily removed is not taken as a sign of inoperability. Such minor details can be found out by PET scan and spiral CT. Recently introduced after laparoscopy came a preoperative laparoscopy when major surgery is being planned. By and large, laparoscopy detects invasion of which organ, where exactly. These details, as and when you want to plan a major surgery, laparoscopic evaluation becomes important. Another important point is because they are usually done in advanced malignancies, prior laparoscopy, you put a patient on therapy or chemotherapy or radiation. This laparoscopy finding acts as a basis to find out whether your chemotherapy and other methods of treatment have helped the patient or not. Next is peritoneal lavage. Peritoneal lavage in a patient who has an advanced malignancy, who is inoperable, where the question of curative treatment does not arise, has no sense. But patients who have operable malignancies, where resective surgery is planned, peritoneal lavage has been said to be useful. Peritoneal lavage is centrifuging and demonstrating malignant cells. In patients where R0 resections were carried out, where a peritoneal lavage is negative, there is a distinct rise in 5-year survival rate. And in patients who are operable, where resection surgery was carried out, but where the peritoneal lavage demonstrated malignant cells, the operative 5-year survival rate dropped. This was proved beyond doubt. Therefore, this is being carried out more and more frequently, obviously in centers where malignancies present early, where curative resections planned, not like us, when most of the malignancies is present in inoperable stage.